Hello everyone, now let us discuss about 2023 ICD 10cm coding guidelines for chapter 10, that is diseases of respiratory system. In the current session we will be discussing about chronic obstructive pulmonary disease and COPD, acute respiratory failure, guidelines regarding acute respiratory failure and guidelines regarding the influenza due to certain identified influenza viruses, ventilator associated pneumonia and vaping disorder. First, coming to chronic obstructive pulmonary disease, that is nothing but COPD and asthma. The codes in the category J44 and J45. J44 deals with chronic obstructive pulmonary disease and J45 deals with asthma. Distinguish between uncomplicated cases and those in acute exacerbation. That is, you will have different codes for uncomplicated asthma and asthma with acute exacerbation. Similarly, uncomplicated COPD and COPD with acute exacerbation. An acute exacerbation is a worsening or a decompensation of a chronic condition. Worsening, in simple words, it is worsening of a chronic condition. An acute exacerbation is not equivalent to an infection superimposed on a chronic condition. So, in other words, simply by exacerbation, we should not come to a conclusion that there is an infection. An acute exacerbation is not equivalent to infection superimposed on chronic condition. Though, exacerbation may be triggered by an infection. It is not compulsory that infection will occur after exacerbation or exacerbation occurs due to infection. It is not mandatory, but infection may occur. It may. Let us see an example. Acute streptococcal bronchitis with acute exacerbation of COPD. Here, this infection is leading to acute exacerbation. Patient already has COPD, which is a chronic condition. Due to streptococcal bronchitis, acute exacerbation of COPD has resulted. So here the codes are, first you should code for acute condition, that is J20.2, which is nothing but acute bronchitis due to streptococcus, followed by J44.0, which is nothing but chronic obstructive pulmonary disease with acute lower respiratory tract infection. Bronchitis is nothing but a lower respiratory tract infection, followed by J44.1, which is nothing but chronic obstructive pulmonary disease with acute exacerbation. So these are the three codes which are essential for this particular scenario. Let us see one more example. Exacerbation of moderate persistent asthma with status asthmaticus. The code here is J45.42, which is nothing but moderate persistent asthma with status asthmaticus. Now coming to second guideline, acute respiratory failure. In acute respiratory failure, we will be focusing about three topics. Acute respiratory failure as principal diagnosis, acute respiratory failure as secondary diagnosis, and sequencing of acute respiratory failure and another acute condition. First, coming to acute respiratory failure as principal diagnosis. So there are two scenarios here. First is acute respiratory failure, which comes under the category J96.0 or J96.2, which is nothing but acute and chronic respiratory failure. It can be assigned as a PDX whenever that is the reason for visit. In simple words, whenever acute respiratory failure or chronic respiratory failure is the reason for visit or reason for admission, then only you need to code acute respiratory failure as PDX. Second case is whenever there is an obstetric related condition, that is whenever there is pregnancy, poisoning, HIV, and in case of newborn cases that provide sequencing direction, they take the precedence. poisoning may be given as PDX. Whenever poisoning is the cause for acute respiratory failure, then poisoning should be the PDX. In similar way, whenever the pregnancy codes, that is chapter 15 codes, they always take precedence that they are the PDX followed by the condition. Under certain exceptions, that is obstetrics, poisoning, HIV and newborn cases, acute respiratory failure cannot be coded as PDX. Let us see an example. Acute hypoxic respiratory failure due to exacerbation of chronic obstructive bronchitis. Here, acute hypoxic respiratory failure due to exacerbation of chronic obstructive bronchitis. J96.01 should be the PDX, that is acute respiratory failure with hypoxia, followed by J44.1, which is nothing but chronic obstructive pulmonary disease with exacerbation. We will make separate session on the specific codes of asthma and COPD. As of now, just focus for chronic obstructive bronchitis also, the code is J44.1, because under J44 you will find various synonyms under which chronic obstructive bronchitis is also there. We will discuss in the next session when we focus specifically about J44 series and J45 series. As of now, here the example PDX should be J96.01, which is nothing but acute respiratory failure with hypoxia, followed by COPD with exacerbation for chronic obstructive bronchitis. Let us see one more example. Acute respiratory failure due to accidental oxycodone overdose. Here, poisoning is the cause for acute respiratory failure. As we have discussed earlier, poisoning code should be PDX. So, T40.2X1A should be the PDX here, which is nothing but poisoning by other opioids, accidental or unintentional, followed by J96.00, which is acute respiratory failure, unspecified whether with hypoxia or hypercapnia. Next case, acute respiratory failure as SDX. Respiratory failure may be listed as SDX if it occurs after the admission. First case is if it occurs after the admission, or if it is present on the admission but does not meet the definition of PDX. In both the cases, respiratory failure may be listed as secondary diagnosis. Now, third topic is sequencing of acute respiratory failure and another acute condition. When a patient is admitted with respiratory failure and another acute condition, for example, myocardial infarction, cerebrovascular accident, aspiration pneumonia, etc., the PDX will not be the same in every situation. This applies whether the other acute condition is a respiratory or a non-respiratory condition. So, whenever there is an acute condition along with acute respiratory failure, whenever there is another acute condition along with acute respiratory failure, first what we must focus whether it is a respiratory related condition or a non-respiratory condition. After categorizing that, selection of the PDX will dependent on the circumstances of the admission. If both the respiratory failure and other acute conditions are equally responsible for occasioning the admission to the hospital and there is no chapter specific sequencing rules, then the guideline regarding two or more diagnoses that are equally meet the definition for PDX may be applied in this situation. Under these guidelines, so whatever the condition is treated first, for that condition is coded first. In some cases, it's okay if either of them are coded as PDX. And if the documentation is not clear as to whether acute respiratory failure and another condition are equally responsible for occasioning the admission, query the provider for clarification. If it is not clear whether which one is responsible for reason for visit, you need to query the provider. Next, coming to next topic in chapter 10, that is influenza due to certain identified influenza viruses. In order to code influenza due to certain identified influenza viruses, code only confirmed cases of influenza due to identified influenza viruses. We need to code only confirmed cases. In order to use code from the category J09 or J10, J9 and J10, we need to code only confirmed cases. And this is an exception to hospital inpatient guidelines. In this context, confirmation. So code only confirmed cases. What is confirmation? Confirmation does not require documentation of positive laboratory testing specific for avian or other novel influenza A or other identified influenza virus. So confirmation does not require documentation of positive test. Simple provider diagnostic statement. The coding should be based on the provider's diagnostic statement that the patient has avian influenza or other novel influenza A from the category J09 or has another particular identified strain of influenza such as H1N1 or H3N2 but not identified as novel or variant that comes under the category J10. Here, let us see an example. Influenza due to, here the physician is documenting influenza due to avian influenza virus with pneumonia. So, the appropriate code is J09.X1, which comes for influenza due to avian influenza with pneumonia. Next, if the provider records suspected or possible or probable avian influenza or novel influenza or other identified influenza, then the appropriate influenza codes from category J11, influenza due to unidentified influenza virus, should be assigned. So whenever the physician records suspected or possible or probable, in such cases you need to code codes from the category J11, influenza due to unidentified influenza virus, and a code from category J09 or J010 should not be assigned in such cases. Next topic is ventilator associated pneumonia. As with all procedural or post-procedural complication, here pneumonia is due to ventilator use. So as with all procedural or post-procedural complications, code assignment is based on the provider's documentation. The code assignment is based on the provider's documentation of the relationship between the condition and the procedure. Whether there is a causal cause and effect relationship between the condition and the procedure, that should be assessed. So code from the category J95.851. This is the final code, J95.851. Ventilator associated pneumonia should be assigned only when provider has documented VAP. That is ventilator associated pneumonia. Provider should document patient is suffering from ventilator associated pneumonia. Then only you need to code J95.851. As an additional code to identify the organism, for example, Pseudomonas aeruginosa, additional code from the category B96.5 should also be assigned. And do not assign any additional code from the category J12 to J18 to identify the type of pneumonia, because here the pneumonia is due to ventilator associated, due to the use of ventilator, and there is a specific code for ventilator associated pneumonia. In that cases, you should not code codes from the category J12 to J18. One more important point is the code J95.851 should not be assigned for the cases where the patient has pneumonia and is on mechanical ventilator. Patient has pneumonia and patient is on mechanical ventilator, but the provider did not specifically state that pneumonia is ventilator associated pneumonia. In those cases also, though the patient has pneumonia and patient is on mechanical ventilator, whenever the physician did not document or did not specifically state pneumonia is ventilator associated pneumonia, then also you should not quote J95.851. And if the documentation is unclear as to whether the patient has a pneumonia that is a complication attributable to the mechanical ventilator, query the provider. Now coming to ventilator associated pneumonia, if it develops after admission, it is not present and it develops after admission. A patient may be admitted with one type of pneumonia. For example, J13, pneumonia due to streptococcal pneumonia, and subsequently develops VAP, that is ventilator associated pneumonia. In this instance, the principal diagnosis would be the appropriate code from the category J12 to J18. That is, pneumonia due to streptococcal pneumonia should only be the PDX, and code J95.851, which is nothing but ventilator associated pneumonia, would be assigned as an additional diagnosis when the provider has also documented the presence of ventilator associated pneumonia. Now finally coming to vaping related disorders. For patients presenting with the conditions related to vaping, assign the code U07.0, vaping related disorder, as the PDX. And for lung injury due to vaping also you need to assign U07.0. Additionally, assign additional codes for other manifestations such as acute respiratory failure or pneumonitis, which come under the category J96.0 and J68.0. Along with vaping related disorder, you can assign additionally, if present, acute respiratory failure or pneumonitis. And associated respiratory signs and symptoms due to vaping, such as cough, shortness of breath, etc., are not coded separately. Associated signs and symptoms are not coded separately when a definitive diagnosis has been established. Once a definitive diagnosis has been established, you should not code the associated cough and shortness of breath. However, because they are respiratory related signs and symptoms, however, it would be appropriate to code separately any gastrointestinal symptoms such as diarrhea and abdominal pain. So simply along with vaping, you can code diarrhea and abdominal pain if they are present, but you should not code cough, shortness of breath, etc. and other associated respiratory signs and symptoms. Thank you for watching. Please subscribe for further videos on medical coding and CPC training.